My name is Jessica Cohen. I'm a faculty member in the Global Health and Population Department. I also have the honor of co-directing Harvard LEAD Fellowship Program, which brings women leaders in global health for a fellowship for the year. We are honored to have Dr. Jalikatu Mustapha joining us today, who's one of our lead fellows. She has a long and prestigious bio, which I'll just summarize here. So she is the Deputy Minister of Health too in Sierra Leone, and she's been serving in that role since July of 2023, where she oversees a large portfolio including clinical and laboratory services, ambulance and referral networks, sexual, reproductive, maternal, child, and adolescent health work, mental health and substance abuse, climate change and health, and public-private partnerships for health. I have heard her speak passionately about her work to strengthen Sierra Leone's health systems and promote integrated approaches to climate health, sexual and reproductive health, and child health. She is also a practicing ophthalmologist and training the next generation of ophthalmologists in Sierra Leone. She led the National Eye Health Program from 2019 to 2023, where she focused on one of the things she'll talk about today, implementing blindness prevention programs. Her work in this realm has earned her the prestigious International Agency for Blindness Prevention Eye Health Hero Award in 2020. An interview with Her Majesty Queen Elizabeth II. She's a public health leader and university lecturer with experience working in Sierra Leone, engaging in research, teaching, and capacity building activities, and mentoring the next generation of healthcare professionals, fostering a culture of innovation and excellence in both clinical and public health practice. It was such an honor to have her on campus recently. The last thing I have to say as a disclaimer is that speakers' remarks are based on their own scholarship and experience, and they speak for themselves and not for Harvard. We are honored to have you here today, Jalika, and I'll let you take it away.
Thank you very much, Jessica and Jessica. It's a real pleasure to be here and talk about my work in Sierra Leone. Yeah, so I wish it could have been in person, but I'm really happy to do this. So let's get started. Let me share my screen. Okay, can you see my screen? Are we good?
Yes.
Okay, awesome. So, yeah, this is a story, I guess, of how we sort of took eye health from, not being factored in anything or being talked about into, I am very proud to say, probably the most talked about program in the Ministry of Health, and one that's been used as an example to set up a mobile outreach program in the Ministry of Health that's integrated everything primary health, including eye health. Yeah, so just a brief background on the Ministry of Health in architecture. So we have the ministry, and then under it, there's a Directorate of Primary Health Care, which oversees the National Eye Health Program. And this program is divided into 4, according to our regions in Sierra Leone: Western Area, Eastern Province, Southern Province, and Northern Province eye care projects. I also put a side note here just to mention that we have really amazing partners who've been working with us, Sightsavers, CBM, and Vision Action, and they will come up a bit more in the presentation. Okay. So some statistics before 2017 or so. So we had a blindness prevalence of almost 6% in people over 50 years. How this is assessed is through a rapid avoidable blindness survey, which is what WHO and the International Agency for Preventing Blindness does in many countries. It's standard, and it provides data that you can easily compare amongst many countries. So usually it assesses people aged 50 or above, because traditionally this is where you expect the most blindness to be. So for Sierra Leone, it was almost 6%, and this is in contrast with many Western countries where it's less than 1%. In the US, it's about 0.8%. For the total population, about 56,000 people are estimated to be blind. And this does not cover severe visual impairment. When you add severe visual impairment, which in essence, these are people who literally cannot function in normal activities, this figure doubles. So more than 90% of our blindness is avoidable and about 60% is treatable. Common causes, cataracts account for the majority. Glaucoma, which is very significant because the difference is cataract causes treatable blindness, glaucoma causes irreversible blindness. So it's quite significant when you look at the impact on the individual's life. And corneal disease, which accounts for about 8%. We had one ophthalmologist for the whole country. This was a population of about, I think we're about 7 million at the time. There was one ophthalmologist, one optometrist in the whole country. And yeah, I mean, we had 4 cataract surgical centers. So the rest of the centers were manned by what we call cataract surgeons, who are nurses who've had a diploma training in cataract surgery, sort of as a step in to clear the cataract cases when there are no ophthalmologists. We also had very high disparities, even in the care and access to care. First of all, of course, geographic. When we had one ophthalmologist and one optometrist, they were both in Freetown here, in the capital city of Freetown, leaving the rest of the country without any access. And we also noticed that women had less access to men in terms of accessing services. Of course, poor people and people with disabilities. Just to give you an example of geographic distribution and disparities, if you look at the map on your right, the size of the circle is telling you the prevalence of blindness according to regions. And you can see like the Northwestern province and Northern province had the highest rates of blindness compared to Western area, which was at 2.5%. It was almost 4 times in the Northern region. Whereas when you look at cataract surgical coverage, the blue tells you the percentage of cataract that has been operated, and the yellow tells you the unoperated cataract. You can see that Western area with the lowest blindness prevalence has the most access to cataract surgical services, whereas Northern Province, for example, with the highest, had the least access to cataract surgical services. When we talk about blindness, for the individual, of course, it impacts to life, impact to families. We usually have kids who are out of school because they have to care for blind parents or grandparents, but also the economic cost to the nation. Nobody thinks about this. Like in a country like Sierra Leone, back then, when you talk about hierarchy of things that, allocations go to, there's maternal health, child health, rightly so, because these are also life and death conditions. But nobody sees blindness as a thing until you look at the economic cost, the cost of impact. When you're talking about childhood blindness, for example, a child who's blind before 5 years almost always dies before the age of 5 in a place like Sierra Leone. And even if they don't die, they have many, many years to live in blindness. So looking at the cost to the country and the government is a way of, I guess, bringing policymakers or decision makers' attention to the actual cost of blindness and not solving blindness. Okay, so we had many challenges in the eye health sector then. We had massive human resource gaps. I mean, we had one ophthalmologist for the whole country. According to WHO, you should have at least 4 ophthalmologists per million people. So back then we needed 28 minimum, and that is the minimum requirement, right? I won't tell you how many ophthalmologists are per population in the US. Of course, it's not just the ophthalmologists, the optometrists, the ophthalmic nurses, other support staff. They were very limited, and many of them were in the Western area, the capital city of Freetown. So the rest of the country didn't have any skilled eye staff. There was a lack of interest in ophthalmology training amongst nurses, doctors, just because people were not talking about ophthalmology. It wasn't really regarded as a specialty. I mean, I'll tell you a funny story. When I decided to be an ophthalmologist, a lot of my professors in medical school called me and said, "Why do you want to waste your talent? You're a great student. Why not be something else?" This was when there was one ophthalmologist in the whole country. Service availability is also a problem because, again, lots of areas in the country did not have access to surgical services. And this is just cataract. If you're talking about high specialty services now, like glaucoma, retina, there was none. Most people who could afford would fly out to Ghana, Nigeria, the US, other countries to access care. And these are just, that was less than 1% of the population, of course. Child eye health was not a thing. The infrastructure was poor, almost non-existent. And we had these big equity issues that I've already talked about. And yeah, also there was little government investment in health, in the eye health sector. And we really relied on just donor support. The donor support was there, but it was also, and we had really great partners who were working in the space, but there was donor fatigue because, like Sightsavers, they were basically the one major partner who had been working in the eye health sector for decades. We had a few other partners, but it was uncoordinated as well. So many things happened between 2017 and 2020, which were a great opportunity for the eye health sector. So first of all, in 2017, 2 additional ophthalmologists, myself and a colleague of mine, we went back to Sierra Leone. And in 2018, we met this guy on the screen, Dr. Williams. I will tell you more about him, but he was a really great opportunity that happened to our eye health sector. And in 2019, I was promoted to, after 2 years of working in Sierra Leone, I was promoted to lead the National Eye Health Program. Before, the one ophthalmologist who was in Sierra Leone was the one ophthalmologist. He was the Eye Health Program manager. He was the lecturer in the medical school. Yeah, he wore many hats, and it's amazing how he did all those jobs. He did an amazing job with everything he was dealing with. Anyway, so in 2019, I got promoted to take over the National Eye Health Program. And in 2020, we were hit by COVID. This was a bad thing for many, in many ways, but for us, it also gave us an opportunity to take a step back because workload reduced, to take a step back, do a proper assessment of the eye health sector and see the gaps and what we could do. And at the same time, we got a 4th ophthalmologist. So I was able to give up some of my clinical days to this 4th ophthalmologist and focus on the administrative aspect of the program. So the first thing we did was do a nationwide assessment of the eye health sector in terms of the infrastructure, the health, the workers, the funding, where it was coming from, the partners available. We discovered people who have been working in eye health sectors that we didn't even know about. We also looked at, we talked about strategy, how are we going to approach this? And we decided to take a health systems lens approach to it. So sort of working alongside the building blocks of the health sector. Another thing I think, which was probably one of the best things we did, was to decide that we were going to make sure advocacy and PR were a big part of whatever we were doing. Because one of the things we noticed was there were people who had been working in the eye health sector space. I mean, they were not enough, but there were people who had been working there, but they were not telling anyone what they were doing. They were not saying anything about what was happening. They were not telling people about what they were seeing, the blindness rates. So basically, nobody knew anything about eye care, which is why the young medical students were not interested in it, which is why probably the government wasn't investing in it as much, because nobody knew the burden or the opportunities that were in the sector. So yeah, we decided we were going to change that. We were going to make as much noise about eye health as possible. So the first thing we did was, after the assessment and the strategy, was to try and integrate eye health into the general primary health care system of Sierra Leone, because we had had a big investment in the primary health sector. There was a lot of access, staff were being trained. So we decided to use the primary health sector, train all the staff on basic eye health care, and then also use that infrastructure to engage a lot of the community and do awareness raising campaigns about eye health. Basically tell people blindness is not permanent. It can be solved. We can actually do something about it. You just need to get to care. The next thing was infrastructure development. So we set up primary eye health units in all the districts, including the ones that had not had any previously. And we had 2 centers in the country which were doing some kind of secondary care, and we decided to upgrade them into tertiary care. One was where I worked, and another one close by. They were both, unfortunately, in Freetown still, but it was a start, and we thought we could use this as a base to now cascade care to the rest of the country. Then the next thing we did was set up mobile outreach services, because it was clear that only 10%, maybe 15% of the population were getting the regular access to surgical services in Freetown, and the rest of the country didn't have this access. So we set up, one of the biggest things we did was to set up a massive mobile outreach program to hard to reach populations, wherein every month we would have 2 big campaigns, sometimes 1, depending on our funding. Yeah, where, as you can see, these are some of the terrains. People live in these places and they have to, if they wanted to get to care, they would normally take 6 to 8 hours sometimes to get to the nearest facility. Sometimes you have to make ferries like this one here just to get care. Can you imagine doing this as a blind person? It's not possible. So we needed to find ways to reach these people. So we would go to these communities, screen them, treat them, do surgery. Many times this was the first time surgery was being performed, eye surgery was being performed in these communities. And we also made sure to give it a gender lens, because we had already had the data that women were being disproportionately disadvantaged from accessing care. So we used the women's groups and the community setup to see how we can access these women faster. And also thanks to partners like Sightsavers, who basically gave resources that were dedicated towards women getting care. In 4 years, we screened over 90,000 patients and over 3,000 surgeries. We like to call them sight restoring surgeries were performed in many of these areas through this outreach program. The outreach program became like the blueprint for the Hospital on Wheels program that the Ministry of Health eventually set up. So we also worked on strengthening our human resource for eye health. We set up local training programs for mid-level staff, ophthalmic nurses, of optometry technicians, ophthalmic clinical health officers who were working in the primary health units. We started continuous medical education. The other good thing that happened was myself and my colleague, who had come back in 2017, we enrolled in the medical school as lecturers. So we had access to the medical students and the nursing students, and we actively worked on them to build up and nurture this interest in ophthalmology. We got our partners to, partnerships, and medical students who were interested for training, because we didn't have any residency training at the time. And again, I have to mention that our partners, they have been amazing in this space. Then we worked on local subspecialty training. So to have a residency program, you need a lot of things. It will take time. But we decided what we can do is see how we can, for example, train one of the ophthalmologists to be a glaucoma specialist and someone else to be a cornea specialist, because these were, services that were not available, and they could be done in a way wherein if we form partnerships with specialists outside Sierra Leone, they could come 1-2 weeks at a time or a couple of months at a time, work with us, train us on these services whilst we provide the services. And then when they leave, we could continue providing these services. And the plan was to start a local residency program in 5 years. This was 2020, by the way. So, yeah, and another thing we did, every time we're going on this outreach, like some of these photos, we would take these medical students along or the interns along, get them hands-on experience, which really worked magic for them, like in terms of nurturing skills and interest in ophthalmology. Okay, another great thing that happened was about a year and a half after heading the National Eye Health Program, because of the work we were doing, especially the mobile outreach work, which was, registering such big impact. I was lucky enough to be nominated and awarded the IAPB. This is the International Agency of Preventable Blindness Eye Health Hero Award. It's the most prestigious award for ophthalmologists working, across the world. And because of that award, we had an interview with Her Majesty the Queen. This and a BBC interview. So because of that, we went viral. Like the eye health work in Sierra Leone went viral. And at this point, I would like to acknowledge my team in Sierra Leone who they made this happen, right? So anyway, we went viral, and we decided, okay, how do we use this to our benefits? As much as we're really proud of the achievement, the first thing we thought was, how do we use this to our benefits? First of all, we use this to leverage a lot of support and recognition by the Ministry of Health. I think this was probably one of the first times that the ministry paid attention to the eye program. And we also decided to use this to leverage more partnerships, especially from the international space. Because again, like I said, we had our partners who had been working for decades, but they could only do so much by themselves. So after this, we like contacted everyone. We, shared our plans, our strategies, our dreams, and it really paid off. We got partnerships from people reaching out from all over the world who wanted to work with us, who had seen what we were doing in Sierra Leone, and many of whom had actually been interested in working in Sierra Leone before, but they didn't know there was like a track record of people working in the space. So one of our biggest partners were, many of them are US-based universities like Duke University, Nebraska. You'll see a list of names here. Many of these people have been remarkable in the work that we've done. And again, our traditional partners are in the blue circle. They were still with us every step of the way. Through these partnerships, we were able to bring in technology, equipment, expertise. We had like glaucoma specialists coming in and working with us. We had retina specialists coming in and working with us. And the most remarkable thing that happened for the program was this guy here, Dr. Lloyd Williams in the blue scrubs, who's working alongside me on the bottom left, who brought in corneal expertise to Sierra Leone. So yes, like I mentioned, we expanded subspecialty care. It was a great thing because we were offering people these services, while at the same time, we were training ourselves and our local ophthalmologists on these skills so that they can continue. Because from the start, right from the start, we always thought about how would we keep this going. Sustainability was a big thing for us. We were offering services, glaucoma, cornea, retina, that were first of its kind in the region. And we transitioned right from the country that sent people out for ophthalmology care to the country that received people for ophthalmology care. So medical tourism, we started getting patients from Guinea, Liberia, coming in because, again, we were first in the region. I'm going to spend some time talking about our corneal transplant program because I think this is the biggest, most fascinating thing we did. So Dr. Williams, who's a corneal specialist from Duke, we started this program in 2022, where we did the first ever corneal transplant in Sierra Leone. And I also should say the first ever organ transplant in Sierra Leone. So we saw ourselves as paving the way for organ transplantation in Sierra Leone. We became trailblazers. We were getting people who had been blind for years, some of them decades, with corneal scars, who were told nothing will ever be done for you. And with one surgery, they were transformed. So Dr. Williams brought in the tissue from the US, which was kindly donated by some of his partners. And the first campaign, I remember, he did most of the surgeries. We were observers most of the time, apart from, a little bit here and there. And then over the next 2 years, by 2024, we, the local ophthalmologists, were doing the surgeries by ourselves. And he was basically just having a holiday. But I have some pictures or videos here where you could hear him teaching me like stepwise how to do the surgery. And I would move on. And I would like to share a few of the success stories. So this right here is 19-year-old Salimatu. She had been blind for 7 years. So we actually found her in the blind school, in one of the blind schools for Sierra Leone. And when we were doing our routine screening exercise, and when we realized we were getting a corneal surgeon coming in, we said, okay, let's bring Salimatu and see if there's something we can do for her. She was blind in both eyes, and she was in blind school. She had been blind since she was 12, and when we found her, she was 19. After surgery, she had, remarkable vision, and she enrolled in normal school. And before, when we talked to Salimatu, the first time we met her, we were like, what do you want to do with your life? She's like, well, nothing. There's nothing I can do with my life. I'm blind. And after surgery, she had all these aspirations. She wanted to be a politician because she wanted to change things. But Salimatu's story was remarkable. When we saw her the next day in clinic, we couldn't even realize it was the same person. Balu Sise, I think, is our most remarkable patient. She was a 55-year-old. She had been blind for 29 years. So since she was in her early 20s, she had been blind, and her husband was also blind. So they met together through the blind Sierra Leone Association for the Blind. And they were both blind. They had 3 children, the oldest being 19. So she had never seen any of her kids, right? Because she was always blind. Balu Sise had surgery. And the next day, In clinic, she couldn't recognize her daughter because she had never seen her. She only recognized her daughter when her daughter spoke to her. And that it was the most emotional moment. And it just showed what was possible when people had access to the right care. And Balu's eyes were like this, corneal scars all over. And after surgery, you could see how clear the eyes were, and you could see that, she could see, and she became the primary breadwinner for her family. And she still is, because again, remember, her husband was blind. I mean, there are many other stories. This is an 11-month-old baby who would have been blind in this eye without the surgery. And Augusta was a young army official who had developed what we call keratoconus in both eyes, and she was going blind, and she would have been discharged because she would not be able to just do her work. And we did surgery for both eyes, and this was her when she was being reintegrated into her job. So another thing we also tackled apart from this was launching a policy, because we never had a policy. There was nothing guiding eye care provision. People would come in, do surgeries, leave. Nobody would follow up. There was, nothing basically written down on paper. So we developed and launched the first ever national eye health policy, again with our partners, and we made it really high profile. By then, we were getting some recognition. We brought in our Minister of Education at the time, who's now the Chief Minister, Dr. Senge, to come in and launch the policy, which was also another PR and advocacy move on our part. And because of the work we did for corneal transplants and all the recognition we were getting, both in the international and local space, I mean, our partners like in Duke and everywhere else, they were putting us on magazines, we were on, international news channels about the work we're doing in Sierra Leone. Again, the ministry was so proud of us that the Minister of Health at the time, 32, tweeted about our work, and this was retweeted by His Excellency the President. And then we got to meet the President, and yeah, a year later, I was appointed Deputy Minister of Health too. I always tell my eye health people that the appointment was basically because of them, because as much as I would have loved to do, it would not have been possible without the dedication of the staff that we had. And the most amazing thing is, most of the time, I or my ophthalmology colleagues got the recognition, but the people who really did the backbone of the work didn't get the recognition. But they knew, we tried to make sure that they knew that they were behind our success. Now, this again, at this point, after all the joy and surprise of being appointed, the thing we thought about the most was, how do we leverage this appointment to improve eye health further? And when I was appointed, the president said to me, there are 4 ophthalmologists at the time, like, make sure you keep up eye health work. And I was very determined. So I negotiated with my boss that a day and a half, the Minister of Health, a day and a half of my time would be spent on eye health, both clinical, administrative, advocacy work, whatever it's called for. So, I mean, we continued the advocacy and the PR work. Now, with the deputy minister role, it gave us even more access and kind of more, I would say, legitimacy to approaching more partners, more people who would be interested in our work. We went to universities in the US alongside my partner, talking about our work, trying to get them. And amazingly, we even went to countries outside Sierra Leone where we were doing corneal transplants. This became a really great thing for us, because here I was, a Sierra Leonean ophthalmologist who's never had any formal corneal training in the US. I was trained in Sierra Leone by a US surgeon in Sierra Leone, and I was able to go do corneal transplant surgeries in El Salvador and other countries. And this was so remarkable, and we really made use of the PR around this. And yeah, it got many more partners interested in working with us, and we were able to bring in resources and technical expertise to Sierra Leone because of this. Just sharing about some of the other subspecialty work we were doing, oculoplastics. This guy had a tumor. This was before surgery, this was even after surgery. Some of these pictures we took and publicized out there everywhere so that people in Sierra Leone could see what was possible. Because again, part of the problem we had was because for decades there was limited access to ophthalmology services. Usually we had people coming in from the West doing a little bit of surgery for a week and leaving. And many Sierra Leoneans would wait. Even if these guys are coming once a year, they would rather wait to see these guys rather than seek local help, because they trusted the foreign doctors more than the local help. So part of the work we had to do was to build trust for the local system, the local ophthalmologists like myself, and the work we were doing. And because of this outreach and the advocacy around the outreach, publicizing our success stories, this has remarkably changed. Now everyone is seeking help. Nobody's waiting for foreign doctors to come because people trust the system. Again, in the middle here is one of my interns who's alongside me. And because of this active effort we're making to get people interested, in 2020, we had 4 ophthalmologists. Now we have 6, and I am very proud to say we have 7 people in training, so that in the next 2 years, we will double our population of ophthalmologists. And even better news to come. But another thing we also did was also start research, because now all of a sudden we had all this expertise, we had all of this equipment coming in, we could write proposals, we got a big grant from the NIH, which, well, yeah, we got a big grant. So we did all this research, we published this research, and you had, I mean, Sierra Leonean doctors and people like me being authors for publications in, you know, reputable journals about ophthalmology. So we're also building our legitimacy in the space, especially with attracting international partners. So part of the role as deputy minister was now, okay, how do I leverage this new role and, you know, build up a stronger political advocacy so that we're considered doing decision making, doing allocations, how we can expand partnership and care and the workforce. So the mobile outreach that we used to do for eye health, we sort of just expanded it. Now we're doing what we call an integrated outreach, wherein we partner with many other areas in the ministry. I use my role as deputy minister to sort of, you know, get everybody on board. So like we go to different districts, we do eye health, we do maternal health, child health, immunizations, mental health checks, health education, cervical cancer screening and treatment, which for many of these places is the first time they're getting this. And we're doing all of this under the banner of the Ministry of Health, but also under the banner as a minister in the government of His Excellency, the President, who is wanting us to take care to the people. When I go to the Ministry of Finance and ask for funding to do eye health outreach as eye health manager, it's very different than when I go to the Minister of Finance and say, I'm going to do an integrated Ministry of Health outreach, as you know, asked by His Excellency the President, because then the funding comes out. So yeah, we've kind of been using this to expand eye health services, but also it's become an opportunity to take other health services to people, especially now as the ministry has a hospital on wheels project, which is really doing that. So we partner with this hospital on wheels project. They're amazing people. We work with them, and we've gone to the most remarkable places providing care for people. This is a summary of the last outreach we did, you know, just before I came for my fellowship. We went for a week to Bond Island, which is one of the most hard to reach areas. You saw the ferry, the makeshift ferry that we had to cross to get there. And yeah, in about 6 days, we screened over 4,000 people with many different consultations and treatments. We had over 2,000 eye patients, and we did 80 sight restoring surgeries. But one of the most remarkable things also was the fact that we screened 256 women for the first time in that district for cervical cancer, and we identified 33 who needed life-saving treatment that they got on the spot. That was very remarkable, and it really resonated with many people, including the president, when we shared this story. So next, after that, a brief video about our last outreach. The plan now is how to expand and improve the eye health sector, but also to ensure long-term program viability, because yeah, it has to continue beyond me, beyond my colleague ophthalmologist. It has to continue even if we're not there. That is the plan. So first of all, we would like to quadruple our eye health workforce, and we cannot afford to do that if we keep sending people outside for training, because it's expensive. Also, people don't want to leave their families for 3-4 years at a time. Sometimes when you send people, they don't come back. So we are thinking, how do we build this program in-house? And we've been working on this, and I'm very proud to say last month we started our residency program with our first local resident. It's not going to be easy. It's a start, and we have many of our partners who are on board with us. Luckily, we have all these universities as partners now who are willing to send in trainers and work with us, and we're trying to see how to build this into a proper program. We want to strengthen research and data, because we need data for decision making. We want to establish a proper child eye health program through a school-based program, which ultimately will lead to a reduction in our blindness prevention rates. The biggest thing we want to do right now is establish an eye center of excellence. This picture here is showing Magabi ICO Cameroon Eye Institute. I know the people because we're all alumni of University of Nairobi. I mean, this was a dream of theirs. They're not dreaming to have mass eye and AR kind of infrastructure. No, at this point, something like this would be a center of excellence because we would have the infrastructure, we would have the technology, we would have our partners coming in. It would be used as a basis for the local residency training, for subspecialty care, for medical tourism, for raising funds for the program, and also as a research hub. So this is the plan. We've advocated to the Ministry of Health. We've gotten the piece of land. Now the plan is to find money to build this center. We're working actively on it, and then we will keep you posted. I put in things from some of the articles and things I shared. A lot of these pictures are not my pictures. They're from our partners, and some of them are from our program, just so you know. And I will end, thank you, but I will end by, sorry, just a second. I hope I can still find it. Oh, here it is. I want to play you a short video. It's a bit fast, just about the work we did, like everybody's.
Bond Island is the most beautiful part of Sierra Leone, home to thousands of resilient people. But for many here, access to quality healthcare has been a long life challenge, especially when it comes to eye care. Today, that is about to change. The Ministry of Health, under the leadership of Deputy Minister of Health, too, has launched a life-changing initiative, bringing specialized eye treatment to Bond Island through the innovative Hospital on Wheels program by the government of Sierra Leone. Patients sitting on the tents as medical personnel conduct eye screenings. Doctors and treatments. Some receive free glasses, whilst others prepare for minor eye surgeries. For many in Bonds, this is the first time receiving professional eye treatment, from cataract surgeries to underlying medical condition. The medical team is working tirelessly to restore sight and improve lives for the people.
From this state in general, see a lot of cases, all of which we have hypertension, two people, especially inside the old people like hypertension, diabetes, and then ulcer, dyspepsia with ulcer back the language. This is so they want in the all, we can see them and then we are going to them. But the other thing is super now surgical case, although we not come for those surgery. Of course, Dr. Mustapha, they are now for the technologists in the city, I program them, teach them right. But then again, we find out some people and then people go different between the gam, elderly people in the gam, young boy, young girl in the gam, and as well in the mother who's about Bella, by inside, by Bella, and so forth. So they want in there, we make proper referral for them, and then let them sort them out in a big facility. But for the one who then gets hypertension, therefore we check back the pressure them, and then we treat them as well.
A simple pair of glasses can change a child's education, a fisherman's livelihood, and elder's ability to live independently. This intervention is more than just healthcare. It is the restoring.
I feel fine. I'm like, thank you. Tell Una, thank you. I tell Madam, thank you. Like a long life and well.
If I know that work in the world, use for the fiber. I don't know. They're really impressive. When they do the surgery and they don't come remove the first bandage or the daily, I feel very well. I see.
I feel good. They are happy. I got enjoy. I tell them about the especially. I see, but they give me mercy for the dropper so that they clear now. I hope that will happen. You know, well, I don't want to I don't drop a man, they don't put in the medicine in the house. But why don't I say I feel fine.
As the hospital with the parts, it leaves behind more than just medical supplies. It leaves behind hope. The hope of a healthier future for the people of Bonds and Sierra Leone.
The health system run its information so we improve access to health. We don't make sure say each community get at least a health center within 5 kilometers, and maybe the 5 community cannot 3 kilometers. But you will find out so you still get some people within a really isolated place, them riverine place, them vulnerable people, within a community, they're still not able to access the health center there. Either because of the diet, because of their also the diet, maybe transportation, so they're not get possible to go with them, so they're not able to come. We also get some services that way as much as we don't try for decentralized healthcare, they're not available in all the districts for all the chief of them. They're very specialized services, like eye surgery, for example. We get an regional town, but they're not in as if some district there and some chief of them. So patient they don't get access to them. So then patient they're not able to get any kind of care there. Plus you take the care and go meet them in the community. And then the mobile outreach day for. You take care and go to the people in the community so that you improve their access to them, it will reduce the cost we associated with them. For this annual outreach, we really don't get limits. Anybody will come this year. For the last 2 days, we worked in a team and in that town, and we don't see over 1,200 children giving the condition. It's hypertension, malaria, typhoid, eye problem, woman problem, so very because of that woman cancer, we don't treat them, either we don't mismarket for them, we give them at least for prevent cervical cancer. So any sickle person carry it, what's we manage and manage, don't over 1,200 of them. If you people in local condition, they will manage, we refer them either number 2 hospital or go hospital. For the surgery, them specifically, eye surgery, they will do for the operation them, and we plan for all the patient they will have. But also, no matter how much patient gets a cancer, with all man will not plan for anybody again, as long as operation will be able to try.
A clear vision, a brighter future. This is the impact of healthcare, reaching the most vulnerable. This is the vision of hope.
It's my baby smile. Baby smile. Okay, that's a joy. Alhamdulillah. Thank you.
Okay, so I'm trying to figure out how to stop sharing, and yeah, so if at the end they were all chanting the name of the president, which, as you can imagine, is a great thing for eye health, because it means when we want funding to do something, we're more likely to get it. So at this point, I really want to acknowledge, first of all, my team in Sierra Leone, who really embraced me as the first and the youngest, the first female and the youngest eye health program manager. It wasn't easy, but they embraced me, they worked with me, and they were so dedicated, who really deserve all the credit. And of course, our partners, Sightsaver, CBM. I really have to mention Dr. Lloyd Williams from Duke University, the corneal specialist, and many others. There are many people, I cannot mention them all. It's been an amazing journey, and I'm really looking forward to what we're going to be able to accomplish in the future. Thank you.
Sorry, it took me a minute to find my reaction button to substitute for applause. Thank you so much. That was incredibly moving and inspiring, Jalika, particularly because I know that that's only actually one part of all that you do that is inspiring. I was wondering, before my dog starts barking, which he's right about to do. If you could talk a little bit more, I'll off the first question, and then I'll ask others for questions about how you built trust in the system. You mentioned that a little, and you talked about sort of social media and that. Can you talk a little bit more about the barriers you face with trust and how you address that?
Yes, definitely. So I'll give you an example. I think it was in 2019, just when I took over the National Eye Health Program as the manager, we organized the first outreach to one of the most remote places, about 7 hours outside the city. So again, these people they've never even been used to a local ophthalmologist. For one, they didn't know what a local ophthalmologist looked like as far as I was concerned. And they had regular outreach by either US-based surgeons or Italian surgeons coming in maybe once a year to do surgery. So even if you were blind, you would wait for a whole year when these guys came to get surgery. Sometimes the need, of course, is so much that they cannot afford to, they don't cover for everyone, and people will have to wait till the next year again. So that was the first place we targeted. We went for outreach. We, took all of our equipment, took a big team, lots of money, and we went to this place. We budgeted for 100 patients, and we had 6 patients turn up because they had been told it was local Sierra Leonean. It was a local Sierra Leonean team that was coming. You can imagine how distressed we were. But I mean, we realized it's just the way people, it's just what they've been used to. So you cannot really, you know, get upset or anything. And we figured out, okay, we need to, it's not just about taking care to people now. We have to find out how to actually get people to accept this care. So we went on a massive campaign, advocacy sensitization campaign, like just we're out there on the radio. I think that's how I developed my public speaking skills, because we're on TV, we're on radio all the time. We had community sessions. I'm just talking about eye health, talking about the fact that we had local staff who were able to perform some of the surgeries now. And slowly, very slowly, we started building up numbers. Like the next outreach we'll go to, we get 20 people show up. We were never discouraged. We'll still pack for 100 patients. And then slowly but surely, we built up the numbers. And also, the people who came, when they had good outcomes, we really put them down and, you know, asked them to go be advocates for us in their respective communities. So our patients also really helped. Like, I mean, the best way to get somebody to come for eye health was to get somebody to do cataract surgery, somebody who had been blind for 5-10 years, to go back to the community as a seeing person. This is a miracle. And then the next time, everyone in the community would come for care. Yeah.
Great. Thank you so much. I'm going to open it up to questions. Either raise your hand or unmute or put your question in the chat, please. Yes, Tanya Michelle, please go ahead.
Yes. Hi, Dr. Jalikatu. I think I muted myself. Sorry about that. Well, first of all, thank you so much for your time and your talk today. It was really inspirational. I think we're in the same leadership organizing and action class with Professor Gans, because that's where I saw the invite to join today. I'm actually running a campaign here in Canada to reduce blindness reductions because I'm a political advisor to the former Minister of Immigration and Citizenship here in Canada. And as some of you may know, we had elections here just last week. And it's a very personal campaign for me because my mom is actually someone who received a corneal transplant at the age of 21 and 26, one in each eye. She lived in a country where there was a civil revolution and there were lots of tear gas bombs. And she rubbed her eyes as a little kid. And then while in her 20s, she had 2 corneal transplants. In February of this year, in 2025, unfortunately, she had a very big misfortune happen to her. She's an elementary school teacher. She was supervising at recess, and one of her students hit her in the eye with a shovel, and they sliced her right eye in half. So I'm currently mobilizing a campaign to have statistics all over the world about blindness prevention. And I was wondering where I could find some of the statistics from your project to be able to present them to the province of Quebec's Ministry of Education in order to reduce ocular safety accidents like the one my mom underwent, since we've gone through a major life change since last February. And I'd like to say thank you for sharing those images of the people that were able to see, because it made me feel incredibly emotional, because I pray every day for her vision to come back. And I had no idea that someone in the same class as me was doing such great work. So once again, congratulations.
Thank you very much, Tanya Michelle. I'm really sorry to hear about your mom. I'm just gonna drop my email in the chat. Feel free to reach out anytime, and I'm happy to share statistics or just talk about things, you know, eye health things.
Very kind. Thank you.
Thank you. Other questions or comments? Suggestions in the chat?
Whilst we're waiting for comments, I'm going to talk a little bit about, you know, you asked me about building trust. I think definitely when you're trying to improve things or set up a kind of a new program, the most important thing is building trust. And this is not just for eye health, for the entire health sector for Sierra Leone. It's been a big problem for us. And just when you take time to just talk to people, listen to their concerns, take the feedback and act on it without judgment, it really helps. And you can imagine what it does for trust in our system when we're getting, again, most of the we got international recognition first before we got local recognition in our country. And that said a lot, okay, because it needed to be recognition by the West for people to see that, okay, we actually have local ophthalmologists who are able to do this work. So I just wanted to mention that.
I really appreciate that. That's something that we need to be learning to do better here. You spoke a little bit about the research work that you do. Since the talk is in an academic home, maybe you could speak a bit about the interplay between the type of service, clinical service, and community service and advocacy work you do, and the interplay between research and your clinical practice and political service.
Yeah, I think so in Sierra Leone, we didn't really have a big research culture. For eye health, definitely not. And it's one of the, well, I would say one of the few good things that came out of the Ebola epidemic, because that's when a lot of interest, there was a lot of interest in Sierra Leone. And when we discovered that Ebola we had big eye manifestations from Ebola, and even Ebola survivors had a lot of eye health problems, a lot of teams came to Sierra Leone and started working. And many of our partnerships, that's how we started with them. People who had come in to work on Ebola patients or Ebola survivors. And that's how we, they wrote all these grants. And when the funding came, we now, they partnered with Ministry of Health, and we do the research together now. So we got training from them, because these are people who had been doing research, for many years, but also a lot of these grants brought in a lot of high-tech equipment, which was able to now positively impact service delivery. And it also helped us to get people interested in ophthalmology, because the best way to get young, ambitious interns or doctors interested in a specialty was when they could see all this high-tech stuff and high-tech research and publications that were coming out. And some of the research also, some of the data we got, we used it as we were trying to plan our national eye health policy. For example, we discovered that, cataract was a big thing, but nobody was talking about glaucoma. Glaucoma was an equally big thing, and it was even causing more irreversible blindness than cataract. So it also influenced our national health policy that we developed. And we also now, we realized that we needed to talk about subspecialty care. Cataract wasn't the only problem. There are many other things that were out there that we needed to talk about. I would say how it's helped us in terms of community and community engagement and trust is the fact that we're working with amazing partners from prestigious universities in the US and in the UK. Definitely gives us accolades amongst our own people as well. And even when we have the publications, amongst international people as well, because then we're able to leverage new partnerships who would bring in more resources to help us improve care.
Just a quick follow-up question. Do you have any suggestions or pleas, I guess, for the global health community in terms of what would be useful for getting more change with regard to eye health? It really struck me watching your talk how transformative this work is. Just the idea that one surgery can just so dramatically change someone's life. Do you have suggestions for what we working in global health can do?
Yeah, so I would say talk to Dr. Lloyd Williams at Duke University. But a joke aside, for many years we had many people coming into Sierra Leone and doing eye health work. Like I said, they're from all over: Italy, Spain, US, UK, China. But they came for a few days, they left, and that was it. Nothing else happened until they came back a year later, and for many decades, nothing improved. So when we started getting the right kind of partners, I'll say, like the guys we're working with now, these people came and asked us, what do you want? What do you want to improve? How do you want to do this? What's your vision and what's your dream, right? So when we say we want subspecialists, they're like, okay, next time I'll bring a glaucoma specialist. When we say we want to be doing research and be involved in this, they're like, okay, we'll do research. We'll teach you how to be first author. Like, they made things happen that it was a win-win situation. They got to do the work they wanted to do, but at the same time, we're developing the local sector and they're helping us build trust in the local sector. When Dr. Williams came for the first time and he was doing the corneal transplants, I mean, we had no idea how to do corneal transplant, but he would literally tell us, sit down, put the stitch so that the patient can see that you can also do this. This is how we start building trust. So I would say, as much as these partnerships, when they happen, it's always, unfortunately, that's the way it is. It's from a position of there's one person up there and there's another person down there. It takes special people to come into a country and view the locals as real partners and, you know, ask for your opinion or even ask you to lead the project, ask you to lead the planning of the project, the implementation, share the credit in the international space, because that's also a big thing. We've had people come in and do research and there's no Sierra Leonean author on the paper. But yeah, when we got the right kind of partners, that's when things really changed. And I think I also want to mention at this point that it's also very important to have like people like site savers who are not academic or they're not implementation partners, but they find resources, but they're also very big, strong advocates. We've had situations where we've come, you know, like almost blow to blow with international partners who just doesn't want to respect the system or the local people, and site savers who have, you know, the sort of clout, I would say, in international space, have intervened and said, no, this is not how it's supposed to be here. You have to respect local people. So it's also very important to have people like that in your corner.
It's awful that you even have to say that. But yeah, a lot of what you're saying resonates with me too about finding the trusted collaborators and growing together and, you know, supporting each other and holding on to them for dear life, because not everyone is going to be come forward with genuine collaboration. I want to thank you so much for all you do. Like I was saying, I'm not sure everyone in this room knows that what you just described is only a part of it. I know you're doing so much to champion women reproductive rights for women and girls as well, and climate health. And oh, we have one more question. So before I hang up, I think if it's okay with you, we are at 2, but we'll take one more question and then we'll say goodbye. Thank you. Please
Yeah.
go ahead.
Sorry, I'm Dr. Tigo, Dr. Jalikatu, very congratulations for this. But I have one question for you, and it's more an ask. So I know Dr. Henry, who did the Eye Institute in Cameroon, very beautiful infrastructure and all. Like, how can you have a clear ask? Let's say if someone today want to have a wing in his name, who do we contact to make a donation for that wing open? That is the type of ask I would love you to do so people can objectively support you in building that institute. Is that something you can guide us on how to do?
Yes, thank you very much, Tego. So actually we're working, I know Henry very well. He's from UON as well, so we're the same alumni. So Henry is actually the inspiration behind this Eye Center of Excellence, what he's doing in Maghrabi. So thank you for that. And yes, we have definite asks and they will come. Just bear with me, they would come very soon. Yeah, I before I go, I see a lot of my great partners online. I would like to mention Lloyd is here, Christos is here. Yeah, just want to say a big hello to them because these are the right kind of partners.
All right. Thank you so much for joining us. I know it's in the evening there, and thank you for switching weeks for your talk. Thank you for all you do. Thanks everyone for coming. Hope you have a great afternoon and evening. Take care, everyone. Bye.
Thank you. Bye, everybody.